Yes, step one is you have to figure out how to unmute yourself. Good evening. Thank you for having us. It's an honor to be able to share with you tonight. And we are going to talk about storm-related natural disasters, preparation for families of children with medical complexity. Maybe. Of course, my slides aren't advancing. Are they advancing now? Here we are. Okay, sorry about that. Before we get started and before we dive into what we're, going to talk about this evening, I wanted to give you some photos of me and Stephanie in the wild, as we say. And I have had the pleasure of working with Stephanie for 4 years while she was a nurse clinician on our team with the complex care service at Duke Hospital. And when you share a cubicle wall with someone, you get to know them really, really well. You know the good days and the bad days and the not so good days. And so here's our team celebrating Halloween, which is one of our favorites at Duke Hospital. We get to all the pediatrics floors dress up and we get to trick or treat with them, and it's a lot of fun. So Stephanie is here as a slice of pizza, which is her favorite food, maybe next to tacos. And then I'm back there in the Happy Val shirt. I was a person who was being shot out of a cannon. So, I mean, why not? So I wanted to just show you that we're real people like you, and we have real community and all that good stuff. And then the other photo is Stephanie and I, we presented our poster at a conference in Memphis in 2019. And we're going to talk about that poster this evening, and here we go. Thank you for having us. So to understand this talk and what we want to share, we need to understand our patient population. Oh, you know what? Let's do our first, we have an icebreaker for y'all. We have a poll. Let's do poll number 1 before we start diving into this. The question is, and this came out of when we were practicing together, is I have always wanted to go to the Iowa State Fair, but I was convinced the other day that maybe there are other state fairs that we need to attend. So what's the best state fair? How do we know? I guess we know. Oh. A surprise to no one, maybe. Iowa #1. Maybe at the end you can all convince me that I should come to your state fair, because that's my favorite, one of my favorite things to do. We have a great state fair here in North Carolina that Stephanie and I have enjoyed immensely. Okay, so let's talk about where we started from and how we got here. Our 10 years ago, the Duke Pediatric Complex Care Service did not exist. We started as a grant program from Medicaid, started as a statewide program called the Child Health Accountable Care Collaborative. And we were tasked with trying to lower medical costs for our Medicaid recipients, and not just any Medicaid recipient, but our medically complex pediatric patients. So we spent some time trying to figure out how we figure out who the target patient is. And that took a while because initially when we started, everybody wanted us to take the asthma patients, but it became very evident very quickly that that was not our patient population. We needed to find the needles in the haystack. We needed to find those Medicaid recipients who are spending close to 34% of the Medicaid budget. So we came up with a variety of ways to do that. And through screenings, we screen every inpatient every day. And we developed a team. And in 2015, we moved from being CHECC to being the complex care service with 2 doctors and an RN and myself. And then around the same time, we started an inpatient service as well, where we could group all of our medically complex, chronically ill patients on the same service. And over time, over the last 8 years, we have grown significantly. We have about 85 patients that we see on our outpatient service, and we have close to 400 patients that we've seen inpatient over the last 8 years. And we have grown to having 10 doctors, a nurse practitioner, 2 nurse clinicians, a social worker, myself, and then another admin person. And we also work on the inpatient side. We round every day with our case manager, our pharmacist, our dietitian, our respiratory therapist, and we put ourselves all in one room so that we can talk strategically about the discharge of all of our patients. And here we are. So what is our patient? What does our patient population look like? And Duke has always been my first medical job. How I got it is a story for a different day. But one of my interesting things about learning medicine over the last 10 years is, they give you the paragraph briefly, and then you get more lines than you can read. But here is one of our patients briefly. And the patients that we're taking care of are G-tube patients, patients requiring ventilation, patients who have a trach, maybe they have a shunt. All of our patients have some kind of equipment that's keeping them alive. So I'm not going to read this. You all are very familiar with this patient population, but I just wanted you to see that this was what we work with on a regular basis. And by regular basis, I mean every day. So if this is our patient population, they come with lots of equipment. And so this is a list of the previous patient's equipment that he has in his home. And when you start to think about a natural disaster and moving one of our patients to safe ground, it's not super easy. So this is all of the equipment that this patient would need to move in order to sustain life. So that being said, it's a little challenging. And I'm going to pass it to Stephanie, who's going to talk about what happens. So if this is our patient population, how do you handle emergency preparedness and how we got into that? Stephanie?
Hey, can you hear me?
Yes, ma'am. Hi.
Okay. All right. Just making sure. So hi, everyone. I know you guys heard a little bit about me already at the beginning, But I just wanted to introduce myself. My name is Stephanie Whitfield. I've been a pediatric nurse for over 17 years. And throughout my career, especially in home health, I developed a passion for caring for children with medical complexities. So my career path has kind of gone all kinds of different directions, but I think it's relevant to what we're talking about and kind of where I am at now. I started in the NICU fresh out of nursing school. I really never thought I was going to work with peds, but life circumstances kind of required me to work more 9 to 5, 8 to 4 type job. I was working, alternating 12-hour shifts. So I went into working with a peds primary care practice. And I also with the NICU, I came into contact with children that had special healthcare needs. A lot of the kids I would see would have like a trach. That was probably the majority of the special healthcare needs that I would see, and maybe a G-tube. But I would also see them with home health nurses, and it, just kind of piqued my interest. And I decided after a few years to go into home health. And I started as a home health, visiting nurse, doing nurse visits. And then I started working as a clinical manager. So I was managing other nurses, CNAs, other, caregivers of pediatric patients. And during that time, the home health agency that I worked with, I also started doing a different role where I was called a transitional care nurse, but basically I would help transition children from the hospital to home. So either they were newly diagnosed with some chronic condition, they had some updated condition, some changes to their care, they needed nursing, skilled nursing, so that type of thing. I would help coordinate all of that between the hospital, the home health agency, the DME. I would kind of coordinate all that, and through that role, I was also a liaison for the home health agency that I worked for. So I would, network and try to connect with other people and just put the name out there for the agency. And I actually came into contact with Val and the other nurse with Duke Complex Care. And I met them, talked with them. I thought what they were doing was really interesting and something I had never heard of before. Care coordination for these type of patients. It just, you don't really hear about it a lot. So a few months later, I actually saw that there was a position open. They had just posted it. I got a job interview, and voila, there I was. So, through my experience in these different areas in healthcare and working with community partners through networking, I found that this patient population requires close collaboration from everyone in the community in order to be prepared for emergencies. So to me, it's like a car. So if the transmission is out, the car can't run. If a child with medical complexity and their family do not know or they're not prepared to handle emergencies like natural disasters, it affects the community at multiple levels. So I'm going to take my chance to do my first poll, poll number 2. And it's let's see if it's going to pop up. There it is. So does your community have a complex care service or something similar? There are many all over the country. Some that we've worked closely with. I'm trying to think. Michigan was one of them, but I know there's several others. But it would be interesting to know if you guys have had that experience in your area in the Midwest. I feel like we need a drum roll. All right, so wow, okay, so the majority of you guys do not have a complex care service. So that's interesting. That was a lot more than I thought it would be. I would say too that there may be a complex care service that you have that you don't know about. It's possible. And the only reason I say that is because even at Duke, the complex care service was like, who's that? I've never heard of them before. It was people, they would reach out to Val all the time. and say, we've never heard of complex care service. What do you do? So I know a lot of children's hospitals may have some type of program. They may not call it complex care. They may call it something else, but certainly I would recommend, just checking in your area and see if there's something like that. So when I began working at the Duke Complex Care Service, it was fall of 2016. At that time, it was Val, another nurse, and the physicians on the team. And so I started in August of 2016, and my first month was spent, just training in my role as a nurse clinician. It involved in admitting complex care patients to the program, and we would develop a care plan that was unique to them. You saw a snippet of the equipment list. We would create that equipment list with these families. It was extensive at times, but we found that was very beneficial. And once we created it, it was there. We could update it really easily. So I think those types of tools are really helpful. We'd also make regular contact with families. So when children were first discharged from the hospital, part of what we were trying to do is prevent those 30-day readmissions, which, do not reflect well on hospitals. And, we were trying to have a cost savings for the hospital. So we would do weekly contact with these patients. It would be 1 to 2 times a week or more, just depending on how much they needed from us at the time. And then after 30 days, we would reach out to them, depending on how stable they were, we would reach out to them monthly. And then over a period of time, maybe 6, 9, 12 months, we would then reach out to them monthly. And it was always a constant contact with them. We were trying to be proactive rather than reactive. And we did have a method to react as well. If there was an acute need for patients, it was their daytime. We had, through the daytime, the nurse and we would cover the service pager. It was also covered after hours by the attending physician. So if there was any kind of needs after hours, like you called in this prescription, it's not getting filled, there's some issue and we need it tonight, or we're having some type of equipment issue, our child is having an acute illness, some type of symptoms that we need help with management. So the families had access to us after hours, even if it wasn't myself or the other nurse. So in 2016, I had been training for a month, and it became a running joke after a while that the other nurse that I worked with, when she was out, our case study, the family would rev up a little bit. They always knew when she was going to be out of town. And it just so happened that she would go out of town every year, September, October. And it was just the time of the year that she took a vacation. And pretty much every time that happened, I felt like a hurricane, all but like 1 year, all but 1 year. So it just so happened that when she went on vacation, Hurricane Matthew showed up. And, so what happened to the patient through all of this? I know on the slide, we have it's a picture of the history of Florence, but I'm going to talk about that one in a minute. But 2016, Hurricane Matthew was kind of unexpected. So in North Carolina, we get our primary weather disaster, emergency preparedness, type situations come from hurricanes. We do have blizzards from time to time. We had a blizzard back in 2015 where I know locally for me, the power was out for over a week. Which, we're not used to that at all. People pretty much freak out. And we have had tornadoes, but it's not as common in North Carolina because of our terrain. We had a tornado that hit about 30 miles from where I live in Greensboro, North Carolina, which was just the oddest event ever. And it caused a lot of damage. But for the most part, we have hurricanes. So since I've been living in North Carolina since I was 10, I've been obsessed with hurricanes. I don't know why. I just like watching them. I'd watch the Weather Channel, and I saw that Hurricane Matthew was forming. And I don't know the timeline of when it formed and when Case Study's father called, but apparently over the weekend he called the physician on the pager and was like, there's a hurricane coming. What are we going to do? We're coming to Duke. We are not staying here if something happens. And so that Monday when I came in, it was we would get updates from the weekend call our end, and so we had to hit the ground running because he was determined he was going to come up to Duke. He was going to come up early, even days before the hurricane. And you know, I'm sure you guys know that, you know, hospitals are not meant to be, especially emergency rooms, they're not meant for those type of situations. That's what emergency shelters are for. And some states have emergency medical centers that are set up. So we were really trying to prevent him from coming. And not so much because we couldn't accommodate him as one patient at that time, but he was one of those patients that when I knew about him from home health before I even started working at Duke, and he was considered an undischargeable patient. So he was in the hospital for over a year, I believe it was. Val, probably support me for that one. I think it was a year. He was in the hospital, and finally complex care got involved and got the ball moving and got a home health agency, and he finally went home. So it was the matter of, we don't want him to come back, because if he comes back, he might break some more, because he's a very fragile child. I don't know if you saw all of his you know, diagnoses, but he is very full, and nobody wants to begin or anymore. Not that we broke him the first time, but you know, they just, if he came, it was a chance he would not leave. So every bit of, you know, proactiveness that we could take to prevent him from coming up, other than for regular appointments, we would do that. But his father was frantic, and I don't know how we did it. It was a coordinated effort, but we were able to talk him out of coming, and we gave him information, you know, plan to go to your local ED. If you know, you run out of power, because he is ventilator dependent, he cannot be off of it a second. He can barely barely tolerates the trach change. So it would need to go to the emergency room or emergency shelter, but his dad was not okay with that idea, which I understand. So the hurricane hit, and it was worse than I think anybody really expected. And what ended up happening to his family was definitely not ideal. Their area got flooded. They lived in a double wide trailer, and where they were located is located close to Cape Fear, North Carolina. It drains directly into the ocean. And he was not, you know, considered like on the beach or a direct impact. He was inland a little bit, but because of that river and all the rain, the flooding was detrimental to that area. And they actually ended up having to get their family members to use a boat to get food and supplies in and out of the home for, I think, at least a week. So it was not an ideal situation. It did not go well. And so we knew that there would probably be another issue next time a hurricane came around. So fast forward to 2018. So 2017, we didn't have a hurricane, thank goodness. Fast forward to 2018, there was Hurricane Florence. Now, I took a particular interest in Hurricane Florence because I noticed it very early. And on this slide, you can see it, and it lasted for over a week before it actually hit us. Probably midway through, in the middle of the Atlantic, the forecast was pretty scary. I was worried, and I live 3 hours from the beach, so it was supposedly going to hit us direct on Category 5. Luckily, when it did hit us, it was to 1, but the way that it worse than Matthew. And so skipping ahead, but so early in that week, when we were hearing that it was going to be very scary, we got a call immediately from the case studies family, the father, who did a lot of his care. And he said, you know what, last time we didn't come, and we regretted it, and we still don't have a generator. This is a family that we tried to get a generator so many times for. And I know you guys probably know with, insurance, Medicaid, things like that, it can be a bear sometimes, especially for something like a generator that's so costly. So still at that time, he did not have a generator, and they said, we're coming up, regardless of what you say, we're coming up. And we're like, just hold on, we're going to try to figure out things for you. And so you can do the next slide. We'll do the next slide. So dealing with case studies family, and also the potential of it affecting almost everybody in our area, including inland to 1, 2, 3 hours away from the coast. We were very worried. So we decided based on the interaction with that patient's family to get a game plan for the entire service. And we prioritized our patient list based on acuity and location. So at that time, I think we had 70-ish patients, and we're like, okay, we're going to try to get a hold of all of them because this could potentially impact all of our patients, but we need to prioritize people based on, their technology needs, their location, and, what are we going to even ask them? So we powwowed. It was normally we would meet every morning for about an hour. This was a several-hour powwow. And, what are we going to ask them? What are we going to direct them to do? And I had done some research after the 2016 hurricane. And it was, Duke would support a lot of professional something for our patient population that would address emergency preparedness, because obviously we were not ready, they were not ready. So I did some research, but I kind of put it on the back burner. We were a growing service, we were very busy, and sometimes it's hard to get to those projects that you really want to get to. So I did have kind of a baseline, but we kind of powwowed all together and we said, okay, we're going to ask patients, families, do you have a plan? Will you be safe? And the reason we would say, will you be safe, is because some families were like, yeah, I live in a trailer, but I'm going to go to my mom's house. They live in a brick home. I think we'll be okay. And some of them, didn't have a plan other than to shelter in place. And they're like, we don't really even know if that's the safest thing to do. Because like I said, a lot of our patients aren't directly on the coast. So, we would ask them those questions. We asked, do you need any medications, any supplies? And they would say yes or no. We would help them with whatever direction that needed to go. And also, here's the pager number if something else comes up. Call us, even if it's in the middle of the hurricane, call us, and we would try to help you the best way we can. You can do the next slide. So through my initial research, I found there is a FEMA app, and at the time there was a North Carolina ready.gov app, which is actually no longer available. I checked it today. But those are both apps that I found that were really helpful. FEMA was helpful because it had Spanish. So there were some of our patients that spoke Spanish, and they both had extensive information on, evacuation centers, where to go, resources that you could just click on the app, which is really nice. So we wanted to share that information with them. We also wanted to find local shelters or their local emergency management system for each county. We would reach out. We reached out to the appropriate people and got phone numbers. So if there was something that we needed to share about shelters or where to go to evacuate, we got that information. We also got information about MedStay. That was actually something that Val found. So it's called MedStay. The gist of it is that it would cover patients' families that were from UNC and Duke, and they would provide or find hotel accommodations for a lower price, and they would offer it for a lower price because their children have medical needs. So we would connect families with MedStay. And on the future slide, we'll see that I think there was about 3 families that needed that because they were in an area they weren't sure how it was going to go. For the time being while the hurricane hits. So we provided that information. We also traverse. So NC that providers use internally in North Carolina. Communication sent to you. So if there's anything urgent, you would get it right away. And because we had already reached that state of emergency time period, we were getting frequent emails. And there was a code or an email that came through with a code. It had a medication code for emergencies. So if a patient said, you know, I'm about a week and a half out from running out, or the family, we're a week and a half out from running out of our medication. I'm scared if we evacuate or there's no power, we won't have the medication, what can we do? And we would call the pharmacies and give them this code that they can type in that's special for state of them to fill their medications early. So there was a few people that needed that help as well. And I believe there's some that actually needed some equipment supply stuff too, feeding tube stuff, you know, to get them through a week or two if need be. And also another resource to deduce, which stands for Duke Enterprise. So deduce at our patient population. It worked with Epic. We used Epic for our patients' information, and it took that information and would plot them on the North Carolina map. We did have one patient in Virginia, and we could make sure we didn't miss anybody that was at a high risk area like the coast. And we used that just to prioritize by location. So next slide is the graph. And this is taken from the board that we presented at that conference. And we kept constant contact with the attendings on our service to make sure we had the same plan for Hurricane Florence. However, in general, no one really knew what to do with these patients, especially technology dependent like our case study. And hospitals and other health agencies were asking us what they should do with their patients, and they all wanted to send them to Duke Hospital. So I know Duke and UNC were sending patients back and forth. So it was kind of alarming to find out that our hospitals really didn't know what to do with these kids either. So through the help of our attendings, we discovered that Duke actually has an Office of Emergency Preparedness and Business Continuity. And through them, we were able to find out that the state had an assigned emergency medical facility that they were setting up for the hurricane, so that people could send, providers could send their patients to that location instead of them coming to the hospitals where it's desperately needed to have emergency room beds for emergencies only, not for just for power. So we thought, great, we're golden. We've got an emergency shelter. They said they can take care of our case study. And we explained all of his needs and everything, and even the difficulty with his family. And they were like, we've got it. We've got everything that we need. But unfortunately, our case study refused to go. And he said, we're coming to Duke. And he called and said they were leaving and showed up at Duke. And he was admitted. He could easily be admitted just looking at him. I mean, he's just so medically fragile. So unfortunately, it didn't go the way that we wanted. On this graph, we do have, he was the only one admitted to Duke. There was one family that had an urgent need for supplies. There was also one family close to the case study in that same area that ended up going to their local ED. because the child was an adolescent and the hospital was more comfortable with their care. So that kind of made sense. That when we called them proactively, they said, well, this is our plan. So I mean, I couldn't really argue with that. They didn't want to go to the shelter either. 4 of our patients required medication refills, 3 required med stay assistance, and 6 of them we had proactive contact. We had proactive contact with all of our patients, but I believe that that's referring to there was 6 that we had a lot of proactive contact with for whatever reason, like coordinating whatever we were coordinating. You can do the next slide. So after the hurricane, I looked over my initial research and FEMA and ready.gov resources and developed a survey based on our patient population and their needs. And through discussions with Val, we determined that Duke's REDCap was the best and most efficient way to send out a survey and collect data from that survey. So REDCap is, I don't know if it's just specific to Duke, but it's a secure web-based application designed to support data capture. And Vala was already sending our families surveys through that system. And so she decided, I'm going to work with REDCap to design how the survey should look and work. And she'll explain that in a little bit more detail. And we used it the next year in 2019, leading into the fall, where another hurricane came through, and that was Hurricane Dorian. So like I said, three out of the 4 years I was there. And since then, it is used upon admission and to the service. So when a patient is admitted to the service, it's an initial survey that we do, and it's updated at least annually. So next slide. So this is the poster board that we presented at the Duke's annual Health Quality and Safety Conference. They do it every year, and the team urged us to create the poster out of all this work and kind of put everything together. And I think that's where a lot of attention came from. It was presented at Duke, and a lot of Duke colleagues were interested in it. And then we also presented it at the Putting Care at the Center 2019, which was in Memphis, I can't talk, excuse me, was in Memphis, Tennessee. It was put on by the National Center for Complex Health and Social Needs, which is an initiative of the Camden Coalition. So if you're not familiar with them, I would highly recommend that you check out their work. And the conference was great. It was fantastic. It was all patient populations. It was a lot of mental health, community health type situations, and it went great. And they have a lot of resources that would be valuable. So Val, it's the next slide and your turn.
Thank you, Stephanie. Just so you know, this is all the work of Stephanie. I'm just here to talk a little bit about it, but this is the survey that we came up with, and it's asking very targeted questions of our family. And this is what it looks like. And I'm gonna just go ahead to the next slide because you can see things a little closer up. But what we did is we asked questions, and then they could answer yes or no or unsure. But regardless, we provided them with a link for more information. So what we found, and what Stephanie found, was there, and we'll say this a couple of times, is there's a lot of information on emergency preparedness for adults, but very, very little information about what that looks like for children, and what does that look like, again, for our patient population. So we developed a bunch of questions that tried to get to the heart of whether or not a family was actually prepared for an actual emergency. And so again, these surveys were sent out once the patient was enrolled in our program. And we found that there's not a lot of surveys like this out there in the wild. And you can see the variety of questions, things that we all think about in our own emergency preparedness, but what does that look like for one of our families? So let's go to poll 3. And do you know about your community emergency plan for disasters? Sort of a softball question. Stephanie's children, most of them play some sort of softball or baseball. So are talking to EMTs. Next time we do this talk, Stephanie, I'm going to have Marcus with like the drum roll, set up the drums behind me, and he can. Oh, interesting. All right. So if you were in that situation and you took our survey, do you know about your community emergency plan for disasters? You could say no, and then click on the link. This is the part of this talk that makes me nervous, but we're going to try it. Stay with me. Stay with me. So that link takes you to a list of our county emergency management agencies. You can click on the county and it will take you to all the information that you need. We found it to be super helpful for our patient population. So each link in the survey is connected to something super useful for all of our patients and their families. All right. Back to this. So again, questions that you all should be familiar with probably, and links. And we've asked that we're willing to share this survey. We've found it to be super helpful with our families. But we understand that we're talking to the Midwest. We did check the map. And we know that the Midwest doesn't necessarily get a lot of hurricanes. So what kind of weather situations, how can we bend what we're sharing with you to fit your community? So I was reading about Midwestern weather. You get lots of blizzards, hail, tornadoes. And then I came across this word. Let's go to our other poll number 4. What is abomagenesis? Let you take a second to read that. A phenomenon or process in which there is a rapid and sustained falling of barometric pressure in the center of a low pressure system. The proper name for a bomb cyclone, which I know some of you experienced last year. Is it both? Is it neither? Am I just being a tricky educator? Let's see what the people say. The answer is actually both. Abomagenesis is actually the proper name for a bomb cyclone. We just thought it was interesting material, you know. So I'm going to hand it back over to Stephanie.
Okay, so In my current role, I work for a company called Voorhis, and I write continuing education courses. And I do a lot of research just for my normal everyday job because our courses are accredited and they require a material to be evidence-based and current best practice. So this is another poll. I think it's the last poll, poll number 5. How do you stay current on recent research in your area of expertise? And the choices are classes like this one, the internet, books, talking to colleagues, none of these, all of these. Okay, all of these, well, that's great. Definitely. And then classes like this one, perfect. So I had developed some of these slides just because I wanted to show some relevant research in this area for emergency preparedness. You know, mind you, there is an extensive amount out there, but I gathered some that I thought were interesting and wanted to share with you guys. So disaster plans are only as good as their assumptions. However, some of these assumptions contradict empirical disaster research studies in the field. So therefore, researchers' findings on disasters can help disaster planners avoid common pitfalls. So let's look at some of the evidence-based practices I found regarding emergency preparedness in children and or adults with medical needs. You could do next slide. So like I said, I grabbed some that caught my attention. There's a lot more research out there, and I highly recommend looking into research relevant to your role and the field you work in. Some of the fun ones that I found interesting were about virtual tabletop exercises, home-based primary care or HBPC, patient assessment tool, emergency preparedness training, EPT curriculum, getting to outcomes guide for community emergency preparedness, and using AI and big data. So next slide. So the first one is about virtual tabletop exercises. So what is VTTX? It is a gathering of professionals that collaborate and practice exercises such as those related to pediatric emergency preparedness. So through this study, they wanted to evaluate if VTTX can help participants improve their emergency preparedness. And they had the following objectives: to improve pediatricians and public health practitioners' preparedness for children's needs with using the virtual tabletop exercises, document follow-up actions, and identify exercise strengths and weaknesses. And they found that participants reported a greater ability to identify strengths and weaknesses of their state's pediatric emergency preparedness than before. And they also found that interprofessional collaboration and knowledge of pediatric emergency preparedness improved. So virtual tabletop exercises, I don't know if any of you guys already do those. I would imagine as working in EMS in those areas, you probably do, but research is showing with this particular study that it's very helpful. And I do, in our references section, we do have those specific studies listed for you guys. Next slide. So getting to outcomes guide for community emergency preparedness was an interesting study. Initial research showed that local health departments needed to be better at engaging communities in their own preparedness, but that the capacity often isn't there. So getting to outcomes, or GTO, was chosen as a strategy to build local health departments' capacity to translate and implement evidence-based practices. GTO is a 10-step process for planning, implementing, evaluating, and improving programs. And they implemented this intervention in 2016 at 3 large local health departments in Southern California. The first steps of GTO are about making a program plan, and they include needs and resources assessment, development of goals and outcomes, identification of evidence-based practices, adaptation of those practices to fit the context, and a capacity assessment and program plan development. And the subsequent 4 steps are meant to be completed after the program is implemented and include process evaluation, outcome evaluation, continuous quality improvement, and sustainability. Based on the pre and post assessments, local health department staff knowledge about GTO steps increased by 9.5%, and practitioner skills increased by 25.4%. And their results indicated that a small engaged group of practitioners can really benefit from this intervention. So next slide is about home-based primary care patient assessment tool, or HBPC. So in my experience as a home health nurse, I know that home health agencies need to prepare their patients for disasters, just like any other healthcare facility. And I'm sure you guys, working with patients out in the community have probably seen the same thing. Unfortunately, few studies have compared how home health use these preparedness tools. And because chronic comorbidities and poor social support, older adults are more vulnerable during disasters. The same can be said for children, especially children with special healthcare needs. So in the US, 53,000 older veterans are served by the Veteran Healthcare Association's Home-Based Primary Care, or HBPC program. This program serves other veterans with complex chronic conditions and support patient preparedness efforts. But practitioners often need guidance on how to approach these efforts because there's a wide range of practices in the field. So during this study, researchers collected baseline characteristics from veterans in the program using the HBPC patient assessment tool for disaster preparedness. They then examined the relationship between these characteristics and disaster preparedness education provided by practitioners. And the study found that through their data collection, that there is a need for homebound patients to receive more disaster preparedness education, which I could have told them that one, but it also found that home health agencies have a unique opportunity to support disaster preparedness for their patient population. And in most cases, homebound patients don't receive this information anywhere else. So from this study, it found that home health agencies and others can improve their patients' preparedness using an assessment tool such as the HBPC. So the next slide, I thought this one was really interesting. Using AI and big data was an interesting evidence-based practice that I found pertinent to today's technological advances. It started first talking about how a community's resilience and resilience to disasters goes hand in hand with its physical, behavioral, social, and environmental well-being, no matter if the disaster is man-made or natural. And assets can help communities withstand, adapt to, and recover from disasters. So what is big data? Big data is a larger, more complex data set, often from new data sources, and it can be a powerful resource for disaster preparation and decision-making. With all the data out there, it's critical to analyze it, and AI plays a big role in doing so. Planners and responders can use artificial intelligence to sort through data and data noise much faster and giving them more time for decisions. The study found that big data and AI can be used to analyze previous disasters, examine lessons learned, and evaluate other data resources such as remote sensors. A community's risk is the result of a hazard or a threat, its level of exposure, and its vulnerability to the threat. So like in North Carolina, we're vulnerable to hurricanes. And you guys have bomb cyclones, so there's that. Several factors can affect disaster risk, including population density, urban planning, and warning systems. Ultimately, using big data and AI can make disaster planning and response more effective and cost-effective. Determining a community's specific data points helps communities determine the vulnerability of the population from their local to the national level. And planning and preparing for disasters involves questions such as whether the community is susceptible to potential threats. Community risk levels will differ based on how many disasters are common in its region. So in partnership with big data, this all creates a plan for handling natural and man-made disasters. And next slide. So I think this is the last evidence-based practice that I found that was interesting. Like I said, there's many more. This one's talking about emergency preparedness training curriculum highlights, which are often an overlooked potential area for emergency preparedness improvement. Many clinicians, including physicians, lack competency-based training when it comes to clinical disasters. And despite recommendations from the Association of American Medical Colleges and the Institute of Medicine, U.S. medical schools have been slow to develop standalone EPT programs. Even though Joint Commission requires regular emergency services facilities to practice disaster drills annually, some hospitals have even been reluctant to establish comprehensive EPT programs. And as you all know, there are two fronts of personnel in a mass casualty event. In an emergency, first responders include EMTs, police, firefighters, paramedics, and others. The second front is, or first receivers include clinicians, hospital workers, mental health providers, public safety officials, community volunteers, trainees, and other lay people. Research shows that more than half of the victims who report directly to hospitals after a mass casualty event bypass first responders. A coordinated health provider response to mass casualty incidents can save lives. The Center of Health Professional Training and Emergency Response developed a high-quality, performance-based EPT curricula using community resources from clinical, public health, private, government, and non-government coalitions. It's a 5-hour course that uses didactics, small group discussions, and mass casualty training scenarios. Along with the core competencies and performance objectives, they use facilitator observation, pre and post tests, and course evaluation. The researchers in this study used the curriculum to evaluate the effects of short courses in clinical provider knowledge, confidence, and skill enhancement. And the participants included physicians, medical students, nurses, emergency managers, mental health providers, EMS personnel, law enforcement officials, and others. And as a result of the study, a trainee's average assessment of disaster preparedness skill improved from 36 to 73 out of 100. In the study, trainees were taught how to respond to a clinical disaster training scenario after taking a half-day, easily reproducible EPT course. Course participants gained a greater understanding of emergency preparedness and improved their comfort with handling clinical disasters, and highly recommended it. So trainees are also completed challenging group and multi-patient scenarios. And furthermore, it actually was completed for little or no cost during the curriculum development process. They used tools such as puzzles and toys to significantly reduce the course financial burden. And furthermore, trainees were used as patients in 2 scenarios, simulations, instead of actors or expensive simulators. So next slide. So some of these evidence-based practice can be implemented in different areas of your communities, but I would find that if what is relevant to you, your role, your community, find what it is that is relevant, and then move forward with a focus on children with special healthcare needs or medical complexity. I definitely recommend our organizations and clinicians implement a survey and questionnaire upon initial enrollment, assessment, even contact to assess patients and families' baseline emergency preparedness. Also, it would be helpful based on what I researched for communities to examine the community assessment for public health emergency response, or CASPER. Some of you may have already heard of CASPER. CASPER is designed to provide public health leaders and emergency managers information about a community so they can make informed decisions. It's quick, relatively inexpensive, and flexible, and it uses a simple reporting format. It uses a valid sampling methodology to collect information at the household level and can be used in disaster and non-disaster settings. A CASPER asks the following questions. What is the household's most preferred method for receiving information about an emergency event? What is your household's primary source of information about the emergency event? And what was your household's most trusted source of information for the emergency event? And with my research on Casper, because I was not familiar with Casper, is I didn't look at all the states, I don't believe, but I saw that there was one Casper in North Dakota, and that's in Burleigh County. I might be saying that wrong. And it was developed in 2012. And it's the knowledge of winter warnings and emergency preparedness. And the goals of that Casper were to assess the acceptability of the winter weather warnings issued by NWS during extremely cold weather events in North Dakota, especially following the recent change in winter weather warnings, and the emergency or disaster preparedness of the community. And the specific questions regarding well water use were also asked to those respondents on well water. I found that there was no Caspers in South Dakota, but as a reference, I also looked in North Carolina. Like I said, I wasn't familiar with it, and there are 31 Caspers in North Carolina. I looked at kind of the general overall what they were, and they included community health opinion surveys, perception of disaster recovery planning, social vulnerability and hazard mitigation planning, assessing disaster preparedness before, during, after emergencies, effectiveness of messaging, factors associated with evacuation, hurricane preparedness, and needs after hurricanes. So Casper can be a helpful tool. I don't know if you guys are able to look into that. That would be one of my other recommendations. Additional steps I would recommend is to identify local, regional, and national pharmacies and resources and create a list of future reference. For children with special healthcare needs or medical complexity, a list of compounding pharmacies is essential. And if you don't already have that already. Also, I would recommend using something like Deduce or a similar technology to geospatially plot patients in preparation for a natural disaster. This could be any type of patient setting. You can easily do it. You would just need obviously their address. And it should be updated periodically, such as every 6 months to a year. And lastly, I would recommend implementing disaster preparedness as a part of a patient's primary healthcare maintenance, and it should be updated at least yearly. Next slide. And that's it. Those are some of the resources. I think it might be all on that one page. So we could use this time next to ask any questions if you have any questions.
Thank you guys so much. The most prevalent question is, can you share your resources?
But of course, yes, we would be proud to. And the slides are y'all's to distribute. So
Okay. We
Yeah.
as the EMSC managers will send those out to everybody who attended tonight. One more question, and then we have to move to our next group of folks. But what would you suggest for areas of the country, like a lot of the Midwest, that are very rural, very remote, don't have a lot of the resources that you have to start in trying to take care of kids with special healthcare needs? How do we find them? And how do you maybe use local resources like churches and other resources in the community that can help and take care of these kids when we need to?
you want that one?
Question.
That is a really hard question.
So in North Carolina, we do have a lot of rural counties, and we found that the emergency management, I don't know if it's offices in those counties, having a list of those for us was a lifesaver, because we didn't know who to reach out to for some of our families. And we had some emergency managers that did help us find the resources that we need. I know that helped definitely with the rural areas. And I would say too, reaching out to your local, to the nearest children's hospital is probably one of the next best steps. And like with Duke, we found out that there was an emergency hospital shelter being set up ahead of time for the hurricane, and that was each hurricane that we experienced. And that was helpful to know because we could pass that along to the communities and emergency managers. Some of them were already aware, some of them didn't know that yet. So those are some of the ideas I have off the top of my head. It's really hard to find people when you don't know where they're at. I would definitely say, like you suggested with churches, they're usually very well connected with their communities. I don't know if you have any other ideas, Val.
I would just say that I feel like in rural communities, everybody knows everybody, right? So I think a lot of times that's like a blessing and a curse, right? So I think sometimes we just have to ask, because I feel like in our rural communities here in North Carolina, like if we're discharging a patient who, for whatever reason, is super medically complex, when we call the local EMTs, they already know about them because the community talks, right?
Yeah.
This has been a pleasure. Thank you for having us. Thank you, Vicki.
Thank you so much. We so very much appreciate your time and your dedication. And I believe Valerie's going to stick around in case you guys have extra questions and we have a chance to answer them at the end. Thank you so much, Stephanie. Thank you, Valerie. All right, our second presentation will begin with a short piece on disaster emergency management, followed by a panel discussion where we'll answer your questions by 4 experts on emergency management. Please submit your questions in the Q&A box, not the chat box, if you have questions for these speakers, and we'll get to as many as we can. 4 expert presenters have given us their time tonight, and let me introduce them very briefly. Matt Van Voorhis is an experienced emergency management professional, bachelor's in emergency management and master's in business administration, director of enterprise emergency operations for Sanford Health, and has been since 2022. He's responsible for 47 medical centers and 224 clinics. He has had the opportunity to lead multiple incident command teams through a variety of emergencies. Jim Pearson was born and raised in Sisseton, South Dakota, and served the city for 12 years on city council and was 6 years as their mayor. He has worked in emergency management since 2008 and has worked with the Sisseton, Wahpeton, Oyate, I practiced that, I'll have you know, as their emergency manager since 2012. In his spare time, he works a small vineyard that he owns with 300 plants and 5 varieties of grapes in Northeast South Dakota. John Siedschlaw is currently the Deputy Director of Emergency Management for the Oglala Sioux Tribe on the Pine Ridge Reservation in South Dakota. Some of his responsibilities include to respond and plan for and act as incident commander or operations section chief on all sorts of disasters, missing persons, MVCs, that sort of thing. He is a search and rescue canine handler on the Pine Ridge Reservation, as well as surrounding areas. He is the chief coroner in one county and the deputy coroner in 2 other counties. He has held several positions in law enforcement, EMS, and the fire service, beginning as a volunteer when he was 16. Harold Timmerman, our 4th presenter, has been Lincoln County Emergency Management Coordinator in South Dakota for 20 years. He has been an active member of the Lennox Volunteer Fire Department since 1970 and served as their chief until 2002 and helped found the service. He was an EMT for 25 years. He is currently chairman of the South Dakota Emergency Management Association. Prior to emergency management, he delivered processed milk for Sioux Falls Dairies for 36 years, and he's been married for 58 years. We'll hand it over to Matt to give us an overview, and then we'll take your questions. Take it away, Matt.
All right, thank you, Vicki, and good evening, everyone. I'm gonna just share my screen real quick. And Vicki, could you just give me a head nod if you can see that PowerPoint? Perfect. All right. So before we get into the panel, we kind of just want to give a brief introduction of what is an emergency manager and really what is emergency management. So by definition, emergency management is the managerial function charged with creating the framework within which communities reduce vulnerability to hazards and cope with disasters. The key thing to that definition is we're charged with the managerial function with creating the framework. So in emergency management, depending on the organization, the community, many times emergency managers, we're not necessarily the ones running the disaster. We're not necessarily the ones in charge telling everyone what to do, but we're tasked with creating the framework for a whole bunch of other people to make sure that they're managing the emergency or the disaster appropriately. Really what the vision of emergency management is we really seek to promote safer, less vulnerable communities with the capacity to cope with hazards and disasters. So you might ask, how do we do that? And so in the bottom right, you can see we really have 4 phases of emergency management. It really kind of all starts with the mitigation and preparedness. These are before an emergency or disaster starts. So preparedness is really getting ready for the next disaster. We know emergencies and disasters are inevitable. So this is kind of the phase that we know we are going to get hit with a variety of hazards. So what can we do to prepare for that? Response is kind of the bread and butter of emergency management. However, it's really only 5% of our time. Usually 95% of the emergency manager's time is spent in either the preparedness or the mitigation or the recovery phase, and not essentially the lights and sirens of response. But again, that response phase is really responding to a hazard that's creating an emergency, disaster, or even a catastrophe. After a community or organization experiences an emergency or disaster, we need to recover. We need to rebuild, essentially. But a key to emergency management is we don't want to rebuild back to normal. We want to rebuild back to a new normal. If we just rebuild back to the regular normal we were before the disaster, we probably have the same vulnerabilities we had previously. So in that recovery phase, as we're getting our constituents, our staff, or our organizations, our communities to recover from that event, we want to build back better. We want to try to reduce some of those vulnerabilities that we probably experienced during or before or after the disaster. And then the last phase of emergency management is really mitigation. And those are long-term sustained projects that we can do to reduce impacts of future threats and hazards. So that's kind of the 4 phases of emergency management. You can kind of see there's a little bit of a continuum. We could be doing all 4 phases of emergency management at once. It doesn't necessarily always follow a succinct, we're in preparedness, and then we go into response, and then we go into recovery. A lot of times these overlap. So emergency management has a lot of different areas or sectors. The first 5 here really kind of go under what we call the public sector, which would be local and community or local and community emergency managers, county emergency managers, state level emergency managers, tribal emergency managers, and then federal emergency managers. We are going to go into those each specifically, but then we have this next that we kind of call the private sector. And I specifically call that healthcare because that's the portion of emergency management that I work in, but we are going to briefly cover all the other different sectors of emergency management. So I think it's important to know that there's emergency management professionals in all different sectors of the United States and even abroad as well. So local and county emergency management, I really kind of group this together because in South Dakota and for a lot of the states in the Midwest, when I say local emergency management, what I mean is more on a city level. In South Dakota, I can only think of 1 or maybe even 2 city level emergency managers. The vast majority are going to be at the county level, at least in South Dakota and for a lot of our rural states. So really county emergency managers help plan for and coordinate emergency response efforts in each county. They really work with local organizations in their county to develop an emergency plan for disasters, really in accordance with the state's overall plan and program. One thing that I did want to highlight in this section is that all disasters start and end locally. We're going to touch on this a little bit, but if a threat or hazard creates an emergency or disaster within a local jurisdiction, a lot of times it's going to, there's going to be so many needs that local jurisdiction can't address. So then they need to call in help, which may be the county, the state, or the federal level. However, it's important to know that when all those resources start coming in, it's really still that local community or that county that should be in charge of that disaster, making sure that they're still the ones calling the shots. They're the ones that the constituents are going to trust. So it's important to know that as an emergency or disaster gets bigger and more help starts to come, that disaster should still be managed by that local jurisdiction. And on the right-hand side, it's the state. I have the state of South Dakota, and I'm just going to use South Dakota for these examples here. But I think most states are probably very similar in how they're structured. As you can see, we have the various counties within the state. Each county has an emergency manager. And then within South Dakota, they do break the counties into various regions. And there are regional emergency managers that work with the counties within those regions. Tribal emergency management. So really tribal emergency managers coordinate efforts. And for this example, on South Dakota reservations, really managing emergency preparedness and mitigation planning. Tribal emergency managers are managed by the tribal governments, and really they're focused on the specific needs and vulnerabilities of those tribal communities. Obviously, tribal communities come with different needs, and so it's very important that those tribal emergency managers are focusing on those needs of their citizens and constituents before, during, and after an emergency or disaster. It's crucial that our tribal emergency managers work closely with federal and state government. And one thing I didn't include would also be their counties that their land also covers in. As you can see on the right-hand side, we have a couple of members on the panel that represent some of the reservations on here. But as you can see, there's a lot of different jurisdictions that these tribal reservations are touching and have to work with. It's very important and can make it quite complex when we're preparing and or responding to an emergency or disaster, especially on the tribal level, because you have to work with your partnering counties, you have to work with the federal government, you have to work with the state government. So they have a lot of different jurisdictions and response authorities and partners that they have to work with. Like I kind of touched on, many of the reservations encompass much of the surrounding counties, and you can see that on the right-hand side with some of the counter reservations that we have in South Dakota. So the State Office of Emergency Management really strives to create a rapid, effective, and compassionate emergency management system that wholly prepares the citizens, communities, and state to be self-reliant when facing emergencies and disasters. So really at the state level, they're working on developing cohesive emergency plans, not only for the state to respond to an emergency or disaster, but also helping the counties and other jurisdictions within the state. They coordinate response efforts for large-scale events. So as I'm sure we'll talk about in the panel, a certain county, and it's exceeding the need of that county, that's where they're going to call on the state to help, and the state's going to come in and help response efforts for some of those larger scale events. And a lot of times the State Office of Emergency Management has a lot of education and training resources for whether it's counties, local emergency management offices, private emergency management offices. They're really focusing on providing that education and resources as well, in addition to obviously responding to large scale disasters. So at the federal level, really supporting citizens and emergency personnel to build, sustain, and improve the nation's capability to prepare for, protect against, respond to, recover from, and mitigate all hazards. And you can see the 4 phases of emergency management coming back to the forefront there. There are other entities of emergency management when we look at the federal level other than FEMA, but I think FEMA is probably the best example. So the map that I included here is the different FEMA regions that FEMA operates in. Surprisingly, I think there's very similar other regions, whether it's EMS regions or trauma regions. But I think one thing to note and to highlight here is, especially since we're talking to mainly Midwest states, for example, in South Dakota, by nature of proximity, we work very closely with Minnesota, Iowa, Nebraska, Wyoming, and Montana, North Dakota. But based on in our FEMA region, we're in FEMA region 8. So we're not necessarily in the same region as Minnesota, Nebraska, Iowa, and a lot of our partners. So that's important to understand that there's a lot of complexities that go into emergency management and how emergency management is structured. So we want to try to figure out as many of these complexities before we move into that response phase. Because if we're trying to respond to an event, emergency, or disaster, it's already very, very complicated. So that's why it's important that in the mitigation phase, the preparedness phase, that we're figuring out, talking about a lot of these complexities, just because the emergency management can get quite complex. The other sector would be the private side. So whether it's healthcare, education, whether it's local school districts or large institutions, nuclear, IT, financial, you name it. Emergency management is really becoming more common in the private sector. Whether it's COVID, cybersecurity, the many natural hazards that our nation is facing any given day, a lot of private industries are wanting to hire in someone or make a department to say, hey, we know as a business, we are vulnerable to a lot of these threats, and we need someone to make sure that we are planning and preparing and responding appropriately to these. And so it's becoming more and more common in the private sector. And depending on the size of the organization, the emergency management structure may be very similar to the county or state level structure. So on the right-hand side, I've kind of highlighted the various regions for the healthcare system that I work for. So like I talked about the complexities in different jurisdictions within emergency management, similar on the private side, I have hospitals and clinics in 5 different states, but we've kind of structured our emergency management structure very similar to a county and state level. So we have the various regions. We have 4 regions, and within each region, we have individual facilities. So we look at those individual facilities kind of like a county. So each individual facility is a county. That county then resides into one of these 4 regions or states, and then kind of more of that enterprise structure, like myself, could consider myself kind of like the federal government almost, making sure that we're all talking and playing well together. So whereas there's a lot of differences between private sector emergency management and public sector emergency management, at the end of the day, we all are kind of structured very similarly. And it's important that private sector emergency managers work closely with their local, state, tribal, and federal partners as well. The last slide that I wanted to touch on was really kind of the disaster declaration process. So a lot of times you'll hear the governor has requested a disaster declaration and the president signs it. And you might be asking yourselves, well, what does that really mean? At the end of the day, it really just allows government agencies and other organizations to access funding and resources to manage the crisis. It speeds stuff up. It allows emergency managers and governors and whatnot to access a lot more funding and resources quicker. Like I mentioned, with the resources and assistance, it opens up individual assistance, public assistance, and then hazard mitigation assistance. On the right-hand side, you can kind of see the formal disaster declaration process. On the private side, we don't follow this. So I think Harold Timmerman and our other tribal reservation emergency managers would probably be able to speak to this much better. But there is a process to, if a community or organization or anything faces a disaster, there is a process to make sure that they're getting the appropriate funds, resources available as soon as possible. So that is all I had for my slide to kind of briefly describe what is emergency management. So I think I'll turn it over to Vicki or someone to kind of kick us off for the panel.
All right, so I'll tell you right now, we have more questions than time probably, but what I'll do is throw out a question, and you guys, just whoever got the short straw or whoever is the best person to answer, go ahead and just answer, okay? Question number 1. What are the common challenges for dealing with children and families in disaster?
I think I can kick this off. I think when we look at a lot of what I'm going to talk about is more on the healthcare side. When we look at specifically pediatrics and children in disasters, what we really think about on the healthcare side is, let's say there's a mass casualty involving a bunch of children. Not only do we need to prepare for those children incoming, but we need to prepare for their families and their parents coming. That's an added complexity that we don't necessarily always get when we're dealing with maybe just adults. So we're really probably dealing with 2 different disasters in one. We're dealing with the disaster of the incoming influx of pediatric patients we need to take care of, but shortly behind them are coming their family and their parents, and good luck keeping them out of your hospital if they know their child is in your hospital. So that's one thing that we really focus in on is, again, we're not just worried about taking care of that patient. Their families and their parents are going to be coming very quickly after that. We need to make sure that we have a good plan and process to handle those family members as well. So that's just one of a few things that we really look at on the healthcare side when dealing with disasters involving children and pediatrics.
Anybody else?
I would also add that we need to make sure that the parents that have special needs kids or daycares and so forth have a plan to activate should some kind of a disaster happen. We can't always rely on the county or someone else to make all those plans. Some of the responsibility has to go back to the parents or the child care or the special needs hospitals that we have. We work with those on a regular basis to make sure that their plans coordinate with ours. And we're able to bring in resources should we need to get additional help.
And if I could, Harold brings up a really good point that that really needs to happen. We had the unfortunate incident of a school fire. Those things happen. Those kids practice that thing, the drill, what they need to do. Unfortunately, this wasn't one that was just a drill. They did have to seek out what turned out to be just a short-term shelter, maybe 3 hours. And it was across a major highway. So we had law enforcement and all the resources that we knew to get there and it was cold. It was in February. Kids didn't bring their coats. Those were all the things that entered into the process, and ultimately the reunification of those school children with their parents who were sitting on the highway, very, very anxious. So yeah, thanks for that input, Harold. I appreciated that.
Another thing too, everybody needs to be aware, and Matt touched on it briefly, with children coming to their facilities. Parents are going to come. There needs to be a totally organized reunification process to make sure that the right kids get matched up with the right parents or guardians. Sometimes there's incidents where one parent may not have custody rights to a child. All this needs to be figured out in advance so we don't get the wrong child with the wrong parent, you might say.
If I could add to that too, Harold, we have on the reservation, it's like extended families. There may be a parent, there may be a guardian, or there may be what's commonly referred to as their nephew, their aunt, their uncle, that really are blood related. And that gets to be quite a situation when you're trying to do the reunification, and it really isn't somebody that really is the guardian of that child. So gets to be quite a situation sometimes.
What do you do about that?
I'd like to kind of reiterate what all three other gentlemen have said, having dealt with multiple mass casualty incidents involving children, pediatrics technically. The reunification is often delayed, and that causes a great deal of stress for the children as well. And like Jim said, on the reservations particularly, the extended family, the Oyate, or the family technically may not be blood. They call, a friend of the family their auntie or their uncle or whatever. And we've been working with the schools and doing some drills where we take the children. We had a bus accident. We had 36 kids that weren't injured, but we couldn't turn them right over to the parents. They still had to be, evaluated medically and that type of deal. We take them to our emergency management facility and then slowly reunite them with the family in accordance to who the school says is the legal guardian. It may not even be a family member is the legal guardian, but our biggest challenge is dealing with these children that are upset. They're pretty wound up, having been in a bus accident or something like that, and then not being able to reunite them with the family or the guardian right off the bat. So we've incorporated with our IHS facility and their mental health people as well as part of the reunification with the family.
Another kind of related question about what do you do with uninjured children who don't have parents or guardians with them? How do you care for them until they can be reunited?
I'll fire up on that one. It's basically like I just just explained. Obviously the injured children are transported by ambulance or what have you, and then the uninjured children, we load them onto another bus, a Suburban, whatever we have available, our tribal transit system, and then we still require EMS to evaluate them, even though we're certain that they're not injured, but they evaluate them and then we reunite them with the family.
One thing we've done with some of our exercises here in Lincoln County, we evacuated one whole school class in Sioux Falls to a very large church. And in there, we were able to entertain those students or those kids until we could make the reunification process happen. And made that as organized as we possibly could. And it takes a long time for that to happen. We had a school shooting in one of our schools in Harrisburg. It was in the high school. All those students had to be transferred to another school in the same town a distance away, and the reunification process happened there. But you need to have these kids or children doing something in the meantime, or they're going to drive you crazy.
Here's a really good question. What is the single greatest hazard where you live that threatens children? Potentially.
Well, any of our winter storms are potentially bad. Tornadoes can happen most any time during the summer. We have flooding events that happen here. Are probably our greatest disasters, and we have plans for all of those to a point, but each disaster needs to be looked at and evaluated for size and scope and responded to by those standards. So we have plans for everything, but you need to be able to change those plans in midstream, you might say, to fit what's actually going on too.
The reservation that we're on here, we actually cover 7 counties. 2 of them are in North Dakota, 5 of them are in South Dakota. And within that, there's 3 tribal schools and there's 5 public schools. So like Harold said, to make sure those plans, once an incident would exceed our capabilities, we're reaching out to other resources. And I always tell people that I'm a subject matter expert in nothing, but I know people who know what to do, and my phone has about 400 or 500 numbers in there that I can reach out to. So those available resources, once it exceeds our capabilities, we're reaching out and looking for help within that in those schools. Part of our issue is we get in this area, they call it a downsloping wind off the Coteau, and it can be calm as can be 30 miles from here, but blowing 50, 60 miles an hour. And that creates a blizzard that comes up quite quickly when there's loose snow out there. So those are hazards that are just going to happen. One thing that the state of South Dakota came out with too was a resource book that covers flooding, fires, and tornado, severe weather. And it's called Tommy Turtle. And we bring that mascot up here to our schools and get them through with the kids. Something that's well received, and I think that's something that helps put some kids with anxiety a little more at ease. It's something we've used a couple times in the last 3 years, and it's just been a good deal. So that's one thing that we don't want kids to do, is get anxiety, or we can't probably stop that. But this resource that we have from the state is an amazing tool that came out of the state of Florida. I think, if I'm correct on that, Harold, you might want to correct me on that. Thank you.
No, I would say too, I was just at an event this last Saturday in Harrisburg with Tommy the Turtle, where we worked with those kids, showed them different books that we have, like Jim alluded to, on the 4 different disasters. And actually the kids get educated, and we hope they take it home to their parents to get them thinking about being prepared for a disaster too, whatever it may be. So educating the parents through the kids is a good thing too.
There's a lot of interest in whether, and if so, how disaster preparedness is different on tribal lands. Is it different?
It can be, because sometimes when you, and we utilize Texas A&M for a couple of things that that we did some tabletop and functional exercises with, and back in 2018 we did one on a pandemic, and we little did we know that would be a reality, you know, a year and a half later. But it helped us prepare for that. I don't know if it's any different, but it's something that we used outside resources to help us, Texas A&M, to help facilitate the training. And out of that disaster that happened in 2019, which was an ice storm, one thing that came out of that was what we call our disaster assistance response employee. We call them DARE. It's something that's helped us get resources out as quickly as possible to tribal members. Where on the county side, you wouldn't see that happening. And it's just a great resource that we have, is that disaster assistance response employee to help us. And they're a group of about 12 people, and they're traveling through blizzards, through you name it, trying to get resources, help, medications, moving dialysis patients to their appointments that are 3 days a week. Quite a process and a lift to make that happen.
And I'd like to, I think it's important that we kind of explain that there's 9 tribes or reservations in the state of South Dakota, and each is unique in its own way. I mean, just for instance, you know, Jim has state and local resources that he can call on to assist, whether it be volunteer fire departments, state, city, tribal law enforcement, that type of deal. On the Pine Ridge Reservation, we basically don't have those resources. My director and I are the resources. We do the response as well as the planning, the recovery, the response, mitigation, you know, the whole 9 yards. So the demographics on each reservation in South Dakota, for sure, are different. We do rely on outside resources at times, emergency first responders, because within the reservation, within the tribe, we don't have those. And so any man-made or natural disaster dealing with children or adults or whatever is pretty complex within itself.
You are correct that it is different on a reservation. I've worked on the Cheyenne Reservation a couple times as part of the state's incident management team when we've had a flooding and an ice storm there, and you're trying to bring them help working within the guidelines of the tribal government, and you have to respect their government and get them as much help as you can and make it fit to their needs and so forth. So,
and in a declared disaster, we prefer to go government to government, you know, the tribe directly to FEMA. Sometimes that's not possible in a smaller disaster, but that is something that Harold brings up, is that sovereignty, I guess, and the want and the willingness to go direct to the Federal Emergency Management Agency should we get a declared disaster declaration.
Yeah, Jim is correct on that. Since I work for Oglala Sioux Tribe Emergency Management, we've gotten 2 presidential disaster declarations. The most recent one was the blizzard in December, you know, where I had 42 inches of snow in 3 days at my house. But the previous one was 2019. And we cooperated with the state of South Dakota to get that presidential disaster declaration. The state didn't have enough monetary damage, if you will, and we did not have enough within the reservation as well. But when we cooperated together, and put the dollar amount of infrastructure damage and so forth, then we met the threshold for FEMA. So, you know, Jim is right. We work directly with FEMA and we work through the state of South Dakota and cooperate on those.
So related question, how can non-tribal agencies, hospitals, you know, all of the folks who are here watching now work better with their cohorts on tribal lands to support them to, you know, to work together? What you want them to know?
If I could, John, I don't want to interrupt anything you were going to say, but what we hope for is that there's open communication, that they come to the exercises. We don't want to meet at the time of a disaster and emergency and exchange business cards. We want to be ready, train with you, along with you, do after action reviews with you, everything that's part of that process. And I think it's just the open communication, the willingness to train together, which is happening up here. We really like that. And I guess that's the biggest thing with our hospitals, along with our Indian Health Services. They train together, and in the event of an unfortunate, the plan will change, but we have something in place that we've tabletop exercised.
I agree with Jim. The training, the open communication, the cooperation is huge. Down here, we work real well with our local or our county emergency management. The Pine Ridge Reservation is part of 3 different counties, and we work real well with a couple of those emergency managers, the local VFDs that are not technically on the reservation, and the state of South Dakota. This morning, I had a meeting up in Pierre with the colonel from the Highway Patrol, Secretary Price from the governor's office, the director of the South Dakota Department of Transportation, and it was reference to closing secondary highways during blizzards and so forth, how we can work that out, get the information out on the 511 road report. But it's the same, you know, whether it's a disaster, it deals with everybody, not just children. But, you know, Jim is correct that the cooperation, the communication, and the training is huge.
Segue, what's a mistake that you see entities make over and over in disasters? Entities being, I guess, EMS, hospital, emergency management, random volunteers.
Yeah, this is Matt. I think one thing I see is not understanding expectations. In a disaster, there's so many different entities and organizations involved. And from what I see time and time again is, I'll just use me for an example. I'm expecting or assuming, let's say Harold from Lincoln County is doing something, but I've never verified. Maybe I haven't even talked to Harold. And when that expectation doesn't happen, and I've based all of my plans on that expectation, it starts to go away pretty quick. And so that's why you'll hear, you know, communication, coordination. That's why it's important, because we need to all understand what are our roles in this disaster? What are all the expectations? What am I expecting of you? What are you expecting of me? And not literally us, but as our organizations and our entities. It just seems like time and time again, we're all assuming someone's going to do that one thing. But then when it comes down to it, everyone's looking at each other going, oh, I thought you were going to do that. I'd say that's probably numero uno for me, is just misunderstanding expectations.
I'm a big proponent of unified command, so that every agency involved, whether it be a school, a hospital, nursing home, whatever, has a person in the emergency operations center to direct all these questions to and get them answered by each agency, so that the right hand always knows what the left hand's doing.
Do you often see difficulty among agencies not getting along during disasters? And what would you do about it?
Yeah, we experience that quite a bit, and every agency, it doesn't matter if it's on the reservation or off the reservation, county, state, whatever. Everybody's a little territorial, you know. But through the planning, the training, the communicating, and like Harold said, unified command, you know, eventually that all meshes. But yeah, within the reservation, within the tribe, within the state, every agency is territorial.
And I'll just add that every disaster gets political right away. And that just goes to show that we need to work that stuff out before the disaster. We need to identify what those issues are, have those tough conversations from an organization to an organization, county to a county, you name it. But we need to figure that out. We gotta get above that. We need to figure it out before disaster, because disasters are incredibly complex. And when you layer on political factors, disagreements, you name it, it just makes it more complex than it already is. So the best way to do that is, I think, just to talk, communicate, coordinate, collaborate, train, exercise, get a mutual understanding ahead of time and not right before or during the disaster.
Matt, I'm metaphorically giving you a high five. Well said.
Okay, school shootings have been frighteningly popular in the news lately. I know particularly here in Iowa. What are your thoughts on preparing for school shootings?
Through our program, my director and I have both attended the FBI active shooter training, the active shooter facility evaluation, and we actually work really well with our local schools. We have, I believe it's 5 tribal or BIE schools on the reservation, 3 parochial schools, and 4 county schools within the Pine Ridge Reservation. And we work fairly well with all of them, but really well with the county schools. We've done active shooter drills. We all the way down to bringing in life flight helicopter and actually flying one of the kids out. They thought that was pretty cool. But you know, we drill, and we use our facility as a gathering point for the reunification of the children and the parents and that type of deal. We're pretty well versed on the active shooter thing down here.
I think you'll find there's been a lot of preparation most everywhere for that type of thing. We've done drills in schools. We do them within the courthouse itself, in the county building. I personally think sometimes the media kind of enhances some of these things by all the coverage they give them, and makes it seem more popular to do. But everybody tries to be as prepared as possible. They've changed the process a little bit for evacuating some of the schools when there's a shooter present. And there too, everything has to be responded to by what's happening at the present moment. But I think everybody here is prepared as much as they can.
And I think, you know, from a healthcare standpoint, you know, healthcare facilities need to look at to say, do you have the appropriate pediatric supplies, and do you have enough? And then do you have the appropriate training for your staff and providers? In South Dakota, we have 1 children's hospital for the entire state. You know, typically what we'll see is you'll have a critical access hospital. And for those that don't know what that is, it's essentially a hospital that has less than 25 beds. There's certain things that also go into what a critical access hospital is, but really it's a hospital in a critical area to serve a rural area. A lot of times what happens in any normal day is a sick kiddo maybe comes into that hospital, and that hospital is looking to get them to the children's hospital in South Dakota right away. But in an active shooter scenario, especially in the rural setting, if you've got 10 pediatric patients, and you may even have more, good luck getting 10 or more of them to the children's hospital as soon as you'd like. So I think regardless of what size hospital you are, everyone needs to be prepared to take in an influx of pediatric patients. And there's a lot that goes into that. Again, supplies, is your personnel trained? And then on top of that, outside of dealing with the pediatric patients, like I mentioned earlier, the families and the parents are going to be coming very shortly after that. And they have a lot of, again, expectations of what the hospital is going to do to give them information and whatnot. So you also need to be prepared and have a plan for that as well.
Our audience is made up of EMS providers, law enforcement, school employees, hospital employees, particularly hospital ED employees, emergency management folks, kind of the whole gamut. Should each entity that would be involved in a disaster have a separate preparedness plan, or should they be part of a collective plan at a county level or some other level? Or both?
In South Dakota, each county has an emergency operation plan that's somewhat standardized throughout the state. But each agency within that county, or even each organization within a city, should have their own basic plan. It'll be coordinated with the county plan should something big happen, you might say. But each one needs to know what they need to do during an emergency.
Right, and I think with our local emergency operation plan, we'd incorporate the annex in our annex, you know, if it's an IHS school, whatever their plan is, to incorporate that in there and at least review that twice a year to make sure that it's at least tabletop exercised.
What are the most important components to a disaster preparedness plan with regard to children specifically?
Possibly knowing what the needs of those children are going to be, if they're special needs, if they're have special healthcare needs or need special equipment. Does the agency bringing them have some of that equipment available? We need to know that soon. So if we need to find more, we can start that process. Through our state here, we have a duty officer program. So if we have a large scale thing happen, we're going to notify the state duty officer immediately, which then triggers notification to anybody on the state level, including the governor, of what's going on. So they can trigger responses according to the needs that we might have and bring us outside resources quickly.
And those resources we can request through a web-based EOC. Sometimes they don't get as quick as we can because we want to look to our local surrounding counties, or hopefully we have an MOU in place with our other tribal partners and help get resources up if they're a deployable asset that they have that we can utilize.
How often should pediatrics be included in disaster drills?
I would say
Every disaster drill.
Yeah.
Sorry, Matt.
Yeah, I think, John, I basically said the same thing at the same time. I think every time, because you just never can predict it. And I think any time that you're going to do a disaster drill, training, or exercise, you got to include pediatrics, because you've got your base level element of adults, but then when you layer on pediatrics on top of that, it just gets more and more complex. So I would advise anytime you're doing a training education drill to incorporate pediatric element every time.
Mm-hmm.
Yeah, I agree with Matt. And in 2019, we got schooled pretty hard on a natural disaster, and we were not prepared for the children, for the pediatrics aspect of things. And I was reaching out all over the state of South Dakota. We had a bomb cyclone and a flood at the same time. And we went so far as to the South Dakota EMS for Children provided life jackets as we were doing rescues of children in the flood area. And So we got schooled pretty hard in 2019 during an actual disaster. And after that, we started trying to include pediatrics, you know, everything as a whole, basically.
I love to hear that. That's great. So
If I
real
could,
obvious-
Vicki, if I could, one thing just to
Yeah.
add to that is the Emergency Management Association. Harold, correct me if I'm wrong, but it was either last year or the year before where they had a disability training for special needs children too. And I thought that was well done and it was timely. And I hope some of the guys brought it back to their areas to implement that into the overall LEOP or local emergency operation plan. Thank you, Vicki.
Real honest question here. We honestly don't have a functional disaster plan, and the thought of creating one is overwhelming. Where do we start? Could be EMS, could be.
Your local emergency management.
Yeah.
That's part of our function, is to assist other agencies, programs, whether it be public or private sector, to help them create an emergency operation plan.
Mhm. So they don't need to reinvent the wheel and start from zero.
Correct.
We might
Mhm.
come in and just ask them some basic questions on how would you respond should this happen? Or
Mhm.
what would you need to do if you could no longer be in your building and you have to evacuate? That
Mhm.
triggers a response from them, and then we would help them organize that into a plan that's usable.
Mhm.
Continuity of operations.
Mhm. Our attendees come from primarily the Midwest, although we always get people from all over, but primarily the Midwest. Is emergency management the same in every state, or is it different?
I would think it has to be basically the same. And that's coordinated through the regions that Matt pointed out earlier, regions throughout the whole United States. So if they want to be a part of a disaster declaration and so forth, they have to meet those FEMA guidelines. So it is maybe a little bit different, but it's going to be basically the same.
I think every region has, like, we don't get many hurricanes, like they said earlier up here, or tsunamis. And the threat hazard risk identification process, you know, incorporating that into the local emergency operation plan is pretty helpful too, I think.
Mhm.
I think it's important to note too, we have this term in emergency management called an all hazards approach. And so, you know, really any type of hazard that we may face, we should have a similar approach to at least starting and responding that. And so basically, regardless of what hazard, and when I say hazard, I mean tornadoes, blizzards, active shooters, you name it, there should be a similar response, at least initially. And by nature of that, kind of like Harold, Jim, and John were saying, is that that's why, you know, it is pretty similar regardless of where you look in emergency management, because we all try to practice that all hazards response.
Right.
Yeah,
We had an incident earlier that was about 3-4 years ago that involved our school, the elementary school, with a hazardous material spill. And that was pretty unique to our area. So the threats just aren't always weather related, but man-made, with a turned over vehicle carrying some stuff that was very hazardous.
So maybe that changes the answer to this question then. What is the potential disaster that we as a people are least prepared for?
You know, I think my two would be cybersecurity, and then if we were to lose all electricity. It's specific. If I look at healthcare, if we lose our internet, we are so handicapped. There are so many hospitals and facilities, and I've got plenty of them in my own footprint, that if we lose our internet for any extended time, it's going to be a major disruption. So I know that's a huge threat in healthcare, is cybersecurity. Whether I mean, you go from payroll to your medical record system to you name it, you start losing some of that, it really hinders hospital operations. And then I think if I look outside of healthcare, I think electrical outages. I mean, if we go dark for more than a couple of days, I mean, heck, a week, 2-3 weeks, And if it scales a large region, there's only so many resources to go around. I can't imagine if the entire United States were to go black for an extended time. I don't know, that to me is just incredibly nerve wracking. And unfortunately, I think our electrical infrastructure is incredibly vulnerable.
I agree with Matt to a great extent. The cybersecurity is huge. In 2008, we had November of 2008, we had a major ice storm and blizzard in my immediate area, and we were without electricity for 15 days. So maybe we're fortunate that on the reservation, we're kind of behind times, but a majority of our homes were heated with wood. So, we were okay without electricity for 15 days. We started bringing in generators and so forth, stuff like that. But that was a long time ago. It doesn't seem that long, but 2008, 2023, quite a long time. And so now even with the pandemic, with COVID, the schools went virtual and they didn't have internet at the homes. So that was a big hindrance right there, and if we would have lost electricity during that, our school kids would have been, without education, without socializing, without the whole 9 yards. So yeah, the cyber stuff and the
And imagine you, Valerie and Stephanie, in talking about electrically dependent people with special healthcare needs. It was a huge issue. Different angle. What type of triage, like field triage, is the best?
Could you clarify what type of triage?
Yeah.
I think EMS triage, in the field, in a disaster, triaging, sorting the folk who need to go to the hospital, who need to go to specialty hospitals.
We
I'm not
would have
sure
to go ahead, John.
I'm not sure exactly what you mean by which type of triage, but in our area, law enforcement and is basically in charge of triage, not EMS, because our EMS personnel need to be treating them patients that they can. And so we try to train with our law enforcement or myself, because I respond to all that stuff as well, that we do the triage versus EMS. So EMS can concentrate on providing the emergency medical care. That
we may do that a little different. I've tried to get each one of our volunteer fire departments set up with a triage kit, so that if we need to set up triage in their area, they can start that. We can expand it as needed. And like John said, our EMS folks are going to be busy treating people, but they're going to help with that also. We'd bring in outside resources to match the need that we have, whether it be from another city or even another county to help us with that.
And I think I would just add whatever triage works best for you. Kind of a scapegoat, but.
Yeah. When should EMS or hospitals contact emergency management? I think meaning if they see something that might be a big issue, when should they reach out and to whom?
Yeah, so I'll take this one. I think it's as soon as you're aware. I mean, whenever we're experiencing something at one of our hospitals, we're calling our response partners right away, because they're gonna, and what they'll tell you is they'll want as much heads up as possible, because if we do need resources, that takes time. If we need personnel, that takes time. So I would just recommend that if you get any inkling that something might be going on, you got to contact and communicate with your response partners right away. But even more importantly than contacting your response partners during an event is before. Again, you don't want to call your emergency manager and introduce yourself and, like Jim said, exchange business cards. When I call Harold, it's not, "Hey Harold, this is Matt from Sanford Health." It's Harold answers, says, "Hey Matt, what do you need?" That's the type of relationship that you need to have with your response partners, and more specifically your emergency managers. But to go back to your question, it's you got to call them right away and communicate early and communicate often.
One thing we have going on here in our area that Matt and I are in, we have a quarterly emergency management meeting, to where we have people from all agencies involved, the city of Sioux Falls, the hospitals, Red Cross, National Guard, Highway Patrol, all these agencies get together and meet, and so we kind of know who each other is. Our 211 folks are there, who we rely on during an emergency to take phone calls for us and direct people to different areas that we assign things to. So it's kind of a coordinated effort that we get together and meet and discuss any issues that we have and talk about trainings that are coming up and so forth. So we have kind of a coordinated effort before anything starts.
I think one thing I'll add too is on the healthcare side, from what I've seen abroad and even in some articles, is there's sometimes a lot of hesitation to share information, especially when you're on the private side. So as emergency managers, or those that are, kind of in charge with disaster planning, and if you're in healthcare or any organization, advocate to communicate to your response partners. Because again, there's always going to be a little bit of maybe a hesitation to share some information for a variety of reasons, but be that voice in the room that advocates to say, "Hey, I think we do need to let some people know." Not saying you need to inform the public of what you've got going on, but you got to start coordinating with your response partners, because if you do need help, you do need resources, you do need personnel, that stuff takes time. And if you wait until you absolutely need it, it's too late.
Okay. How much and what type of equipment should different entities keep aside for a disaster? Like, I think in a disaster involving pediatrics, EMS providers, a lot of our Midwest EMS providers are volunteer-based services. There isn't a lot of money there. The critical access hospitals, also not a lot of money. How much is enough? What kind of a stockpile do you need? And are there ways to get funding for that?
Matt may be a little bit more familiar with that type of thing. When you look at smaller agencies trying to stockpile a lot of expensive stuff, it may not happen. Maybe they can make provisions or look for possibilities to get those supplies should they need them on short notice from different suppliers, would be my best answer to that question, probably.
Yeah, and I think there are various equations and calculations out there actually that say, if you're planning for X number of patients, here's the amount of supplies that you need. I'd have to look into it a little bit more, but there are those equations out there. Whether they're pediatric specific or not, I don't recall, but it's a great question. And I don't know if any of us are going to have a great answer, other than you do the best you can. As emergency managers and those in charge of disaster planning, we're not the ones usually signing our names on the checkbook at the end of the day. So we're under a lot of different constraints. So basically, you do the best you can. I think one piece of advice would be, look at your local jurisdiction, your local community, your county, look around to say, what's the most likely pediatric event that we could have, and try to plan for that. Plan for it, do a tabletop exercise. As you're talking through this event, you may find the answer. How many schools do you have in the area? Do you have local events that sponsor pediatric events, and how many kids usually go to that? I mean, those are the kind of things you need to role play with your teams and try to get some answers to that. But unfortunately, I don't think there is a very good answer to that. I just think you got to do the best you can, and you do want some, more the merrier, but understanding that there are a lot of financial constraints with that.
Basically, there never is enough. financial restraints, you know, so on and so forth. But having dealt with a basically a mass casualty incident in my area that unfortunately involved my family, there's not enough pediatric equipment. We were extremely fortunate in our area, and through, I think, throughout South Dakota, that through the South Dakota EMS for Children, they provided pediatric trauma kits for our local volunteer ambulance services. You know, I put equipment in my unit. I'm not involved or employed EMS anymore, but you know, I had a PD board, pediatric trauma kit in my response unit, and they provided that equipment for a lot of our VFDs in the area as well. And that was big, but there's never enough.
School-related question. Does each state Department of Education create disaster plans for the schools? Like, do the schools all have the same plan, or do they all have different plans? And how best can EMS agencies and hospitals work with schools to pre-plan?
That's probably a Matt question.
Yeah, you know, I don't know the specifics of if there's, you know, state regulations that say each school has to have I imagine there probably is, and I would imagine there probably are resources for schools to have them. But from my experience, it is so crucial, especially from an EMS and a hospital healthcare standpoint, that you are talking with those schools. And I'll give an example. One of the local school districts, and it wasn't Harold's district, so we'll just say that outright. But one of the local school districts was doing a reunification exercise. And we got wind of that. I can't remember if they invited us or if we asked to be a part of it, but that in and of itself is important. If your local school district is doing a reunification exercise, ask to be involved, and whether you're just sitting observing or you have a role in it, it doesn't matter. But we were a part of this school reunification exercise. Essentially, there was a local school that had an active shooter, and they actually transported kids off to the reunification site. Again, this was all an exercise. But from the hospital standpoint, what we were really curious about was that communication of, hey, you know, eventually you're going to get to the point to where you've got 20 kids that are not at the reunification site. And if you were part of an armed intruder, unfortunately, that kiddo is probably still at the school or is now at one of the hospitals. So we went up to the table that was kind of in charge of doing the head counts and saying who's here and who's not. We went up to this table and said, hey, we're with the healthcare organization in town. Just wondering if you'd be able to share this information with us in a real event. And they very quickly said, no, we cannot share this information. School districts essentially have their version of HIPAA called FERPA, I believe, which is kind of essentially, basically, you can't release certain information and whatnot. But that was very concerning to us as a healthcare system, because as we're getting these sometimes unidentified kiddos, sometimes they can't speak, so we're having a lot of difficulties identifying them. It sure would be very, very helpful if we could get some of that information from the reunification site to say, hey, here's the list of 20 kids that aren't here, and if we've got 12 of those, we can kind of start going down the line of identifying some of those. Whereas that table within that reunification exercise said they would not share that information with us. When I brought that back to some leadership with that school district and their safety director, emergency management type person, we kind of worked through it and ultimately did end up with, yes, they would share that information with us. But if maybe we wouldn't have had that conversation and maybe asked that question in the middle of an event, maybe we would have gotten that same response of not sharing that information. And again, these are all the things that we want to talk through before. There's so many different regulations, whether it's HIPAA or FERPA, that says you can't do this. Well, in a disaster, sometimes a lot of that goes out the window, and you just need to be able to share that information. So it's just so important that you're talking with these entities. And again, expectations. Don't assume that they're going to share that information. Don't assume they're going to do X, Y, Z. Go in and ask those questions and see, are they actually going to do that? And when you find some of those gaps or barriers, work through it, because those are things you want to work through before, rather than having to find it out in the middle of an event.
Can you give an example of a disaster that you were a part of and tell us the good and bad about how it was managed?
I would inject that during COVID, I would go back to our disaster assistance response employee. That couldn't have worked any better with the feeding program they have to do to feed the schools. We even had to feed the inmates one time at our local jail where they couldn't provide that because of supply chain. Those went very well. I can't really think of a negative on that, but when you go into the disaster declaration that was there and 100% funding for feeding category B stuff, which is emergency protective measures, the tribe spent $1.3 million, and with 100% reimbursement through FEMA, we've gotten that all reimbursed. So that's something that went very well. Downside is we could use twice the disaster assistance employees that we do have, but we have limited capability there and limited resources of people. So that's what I would offer.
I think, one I can give, in 2019, Sioux Falls was hit by 3 tornadoes. One of those tornadoes actually hit so we have 2 major health systems in the city of Sioux Falls. One of those tornadoes actually hit the behavioral health hospital of that other health system. And so at that point, I can't remember, but they essentially needed to evacuate 92 or 96 behavioral health patients. It was about 11 o'clock at night. So of course we activated our incident command team because we were assuming we got to start taking in some of these patients. What worked really well about that event is we've exercised with the other healthcare system. I think normal business, we're fierce rivals. And when I say we, I don't mean the emergency managers, but the systems. But in a time of crisis, we do come together. We exercise as an entire community. We work on preparedness, planning, and trainings all together. So what went really well is we established that communication, coordination, collaboration very, very quickly with them. Ultimately ended up, they were able to house a lot of their patients at their other large tertiary site in town. But maybe it didn't necessarily not go well, but what we were really struggling with was, of the 96 patients, half were peds and half were adults. We are not a behavioral health hospital. So we're thinking, okay, we're starting to open up rooms, but these rooms are not behavioral health rooms. So what kind of litigation risks does that come with? And then we're thinking, okay, are we going to take the adults or are we going to take the peds? And as we're kind of working through all these things, we were like, it's too bad we didn't have a plan already in place for that. But that's just an example of, you can't plan for everything. But what went well was the communication and coordination with the other health system. And then, not that it didn't not go well, but it could have, is holy moly, what do we do as a tertiary acute care hospital trying to take in behavioral health patients that we don't usually take care of? So, I mean, just another example of, you think you've planned and prepared for everything and something happens and you're looking around the table going, we don't really have a plan for this, but here's why we have the incident command system. So just an example.
Any other thoughts? 2 more questions, I think. One is, communication is always a challenge in disaster. What's your preferred method of communication? Phone, computer, radio, something else?
All of the above. Basically, because I end up being the incident commander for most of our disasters and incidents. I have 2 mobile radios, 2 portable radios, and 2 cell phones. And many times they're all going off at the same time. And then I also have this computer in my unit that is email, but email doesn't work for me because I'm too busy doing the other thing. But for us, radio is the best. I can communicate with all state resources, local VFDs, state OEM, and our local stuff as well, via radio. For us, radio works the best.
John's right. All 3 may need to be utilized at some point or some way. If radio is busy, you can't get on it, maybe a cell phone will work. And we have a system where we can kind of prioritize emergency traffic on our cell phone system even. So one of those is bound to work. You just have to figure out which one is best at the time you want to use it.
Yeah, I agree with that. The radio is the best, and we're in a state here where we're upgrading the system to this Project 25, and there's an issue there where some people haven't planned well to do that switch over, and it's coming quicker than we want. But the P25 radio compliant and the radios of digital mobile radios or handhelds need to work, and those that aren't planning for that upgrade, we need to encourage that. So yeah, the radios are the best way to communicate, I believe.
And none of the methods are perfect. In our area down here, geographically, there's areas where I have no cell service, I have no digital radio service, I have no analog radio service, smoke signals. But I mean, and we're working on that. We're trying to get, mobile cell phone repeaters, or mobile digital radio repeater, but none of them are perfect, but radio is the best.
Last question. Folks watching today would like to know how they can help. Where do they volunteer? Who do they talk to get plugged in ahead of the need so that they can respond when necessary?
They can start with their emergency manager or the agency that they're looking to help. If you're looking to help a healthcare system, contact them and see if there's anything they can do. If you're looking county government, a school, any of those agencies are going to be needing some type of help during an emergency. And if they know in advance you're willing to do that and may have some training towards that goal, I'm sure they'll welcome you on board.
A lot of counties also have community emergency response teams. That would be see if your county has that established. We developed on the reservation here also, in addition to the community emergency response teams, we also did a teen CERT. Kids want to help, kids want to volunteer and help, and we welcome them in limited capabilities. We don't put them at risk, obviously, but they've been a great help during the times of disaster as well.
And I would also advocate. Oh, go ahead, John.
Oh, I'm sorry. I agree. Get your information to your local emergency management director of a county. As Matt pointed out, in South Dakota, there is a few municipal emergency management individuals, but no matter what state, I'm certain that there's a county emergency management, and then they can funnel that information to the state emergency management, and they'll have a list of individuals, I guess, that are willing to help, and their credentials basically through the state Office of Emergency Management, the EOC. And I guess that'd be the best way, even for the reservation. If we're looking for something that we don't have, we go through the state emergency management and pick their brain and get their information.
Mm-hmm.
And there is a federal system called ESAR-VIP, or Emergency System for Advanced Registration of Volunteer Health Professionals. That's why we just say ESAR-VIP. It's basically a federal program that you as a medical professional can go in and verify you are who you say you are, because in a disaster, I mean, we will need the help as well, because it's not atypical in a mass casualty event for true medical professionals to show up to hospitals they don't work at and say, hey, I'm a nurse, I'm a PA, I can help. But as a hospital, we're not going to let you in until we can for sure verify who you are. And that takes time. But if you talk to your local emergency manager and or sign up for this ESAR-VIP program, that really speeds up that process, because you've essentially done that verification ahead of time, and we can let you in and have you help us out sooner rather than later via that. So, and it's ESAR-VHP. So that's ESAR-VIP.
In South Dakota, there's one. I'm sorry. And multiple states around us, I know, it's one way to get that information is get with your local emergency management and enter it through the Salamander Life program, the credentialing system. Basically, we use that down here for all our tribal programs, volunteer the VFDs, everything, and that's basically a clearinghouse for information on individuals' credentials and so forth.
Nice. Nice. All right. I want to respect everyone's time. I want to thank Matt, John, Jim, and Harold so much for a great discussion. We put you guys on the spot. That was a lot of questions, and you did great. I do also want to thank Valerie and Stephanie again. I know that Valerie's still here. We really appreciate your time and your willingness to, to be on the spot and to spend time with folks. Everybody here is looking to take the best care of patients and the best care of kids that we all can. And we appreciate you very much and what you contribute to that. A couple of things I want to send you away with. One would be the super secret, top secret code word, which you'll be surprised to find is disaster. Disaster is the super secret code word. Be sure to complete your evaluation to get your credit. Let's see, it says, attendance doesn't automatically grant credit. To claim your credit and print your certificate, follow the instructions in your account and input the word disaster and complete the evaluation. You do need to complete the evaluation and get your certificate within 30 days of the conclusion of the event, which is today. So 30 days from today, and then it disappears. And your certificates can be found in completed activities by clicking the download button in your account. If you have any trouble whatsoever, contact your state EMSC program manager, and we'd be happy to help you. If your EMS providers watching in a group, be sure and get those rosters turned in by tomorrow night. And again, feel free to reach out to us with any questions. Thank you so much for everything you all do for kids and for your willingness to spend your evening with us. Stay safe, take care of each other, and good night. Thank you.